Welcome to another installment of Ask Us Anything About here from the Milton S. Hershey Medical Center. Today it's Ask Us Anything About prostate cancer. It was in a media interview earlier today that Dr. Ben Stiller revealed that he was diagnosed with prostate cancer 2 years ago, and he underwent laparoscopic surgery to cure it. His diagnosis came after a prostate-specific antigen or PSA test that he underwent at age 46. It flagged the issue. A couple years later, he had an MRI that confirmed the diagnosis, along with a biopsy as well. Now, Stiller does not have a family history of prostate cancer nor any specific risk factors, yet his doctor decided to include that PSA test in a routine physical at age 46 for him. Now, that probably has some men wondering exactly when they should start getting a PSA test, because the common guidance we often hear is around age 50. So here to help answer some of those questions for us is Dr. Jay Rahman. He's head of the Division of Urology here at the Milton S. Hershey Medical Center. Dr. Rahman, thanks for making the time today.
No, thanks very much, Scott. Appreciate it.
Yeah, absolutely. Let's start by talking about the PSA test. For people who may not know what it is, what exactly is it? What does it tell you as a physician?
So the PSA test is a blood test. PSA is prostate-specific antigen. It's a protein. And any man with a prostate will have some PSA circulating in the blood. What we know is that higher PSA levels can be a clue that there is some problem within the prostate. Maybe an enlarged prostate, maybe inflammation, maybe infection. But what we really worry about the most is, could a high PSA be a sign of prostate cancer?
So it doesn't indicate a definite diagnosis of cancer. It takes things, well, I guess in Ben Stiller's case, it was an MRI and then a biopsy. Is that a typical course that these things follow in diagnosing?
Yes, I think you're absolutely right. So a PSA being elevated simply is a clue that there may be some problem, some pathology in the prostate, but it certainly is not diagnostic of cancer. In fact, the only way that we can truly diagnose cancer is through a prostate biopsy, where we take small specimens, small snippets from the prostate, and then pathologists look at this under a microscope and determine, okay, does this snippet look like cancer or not? MRI is a really interesting tool that's been used increasingly to help us really determine, is a biopsy warranted, and what portions of the prostate are suspicious areas that may require greater detail in biopsy or greater attention at the time of biopsy. I would tell you that the standard of care is some centers tend to use biopsy as well as MRI. Others simply take an elevated PSA, and if the PSA is high enough, progress directly to biopsy without using MRI as an adjunct.
Now, is PSA the main early diagnostic tool for something like prostate cancer, or are there other things you use at that early stage?
Yeah, so I think when we look at diagnostic tools for prostate cancer, PSA was developed back in 1995. So it sort of has the street credibility. It's been there for 20 years. It is probably our most well-used and most often used test. But I think owing to some of the limitations, owing to the fact that not all men with an elevated PSA will necessarily have cancer, there's some newer tests that have come out. Prostate Health Index, or PHI, the PCA3 test, which is prostate cancer antigen test, Pro-PSA. So these are all different versions that can be used in a diagnostic screening setting, but many of them have been more in an exploratory phase, and not any of them have really supplanted PSA in 2016.
You're watching Ask Us Anything About Prostate Cancer from the Milton S. Hershey Medical Center here on Facebook Live. Feel free to add your questions to the comment field below, and we'll pitch them over here to Dr. Rahman and ask him those questions. And I guess the next question I have is about the issue that's raised by Ben Stiller with his diagnosis. He and his doctor were on a satellite radio interview this morning saying, listen, Ben here was diagnosed because of a PSA test he had at age 46, 4 years before the kind of standard guidelines recommend having it at age 50. So he's encouraging every man 40 and older to have a conversation with their doctor. What's your take on that?
So I think Ben Stiller's case is an unusual one. And I think if you look at national statistics on the diagnosis of prostate cancer and rates of prostate cancer, when you have men under 50 years of age, you're looking at about 5% of men having cancer. And so one of the challenges is appropriately screening patients. So you don't want to necessarily screen everyone to identify a very few number that may benefit from diagnosis and therapy. I seem to subscribe very much to the idea of our national guidelines, which are the American Urologic Association, which is really screening patients between ages 50 and 65 who have an average life expectancy anticipated at 10 years or greater. The idea is at that time frame, you will likely pick up a high enough percentage of men with cancers and cancers that may require therapy. And so although his case is a unique one and clearly he has benefited from early diagnosis, I would still subscribe that 50 years of age, unless there are highly suspicious features in family, would be when I would start screening for guidelines.
I guess it all comes down to trying to strike a balance, right, between making sure you catch it early and not over-testing. I
think that's absolutely right. So I think when you look at some of the controversies associated with PSA, the issue is largely overuse of PSA in patients perhaps who are too young, or even those who are too old, those who are maybe 75, 80, 85, who may die of other causes within 3 to 5 years, and one could argue very much what's the utility of sending a PSA test at that point, diagnosing that person with prostate cancer if they're likely to die of some other cause. So I really think that appropriate use and counseling for when we use the PSA, how do we react to a PSA being high? Do we need to repeat these values? Do we need to progress to a biopsy? Sort of judicious use of the test, I think, is what's critical to the whole screening process.
The numbers I've heard, is it about 1 in 7 men in their lifetime will face a diagnosis of prostate cancer? Is that the latest?
That's right. So in 2016, 1 in 7 men, and really to put it into context, about 30,000 men a year will die of prostate cancer. So when we talk about the fact that men are diagnosed, many are diagnosed at a very favorable stage, similar to Ben Stiller. But we have to remember at the end of the day that there are prostate cancers that are aggressive, and about 30,000 men a year do die of this disease.
Every person's cancer is different. Some will have a slow-growing tumor, right, and some could be rather aggressive. His, he said, had a Gleason score of 7, which he said made it a mid-range aggressive tumor. Could you talk about what that means, what the Gleason score is, and that sort of deal?
Sure. So I think you're absolutely correct. When you look at prostate cancer, this is certainly not one homogeneous entity. So you can have low-risk prostate cancers, intermediate risk, and high risk. And the way that we assign a lot of these low, intermediate, and high risk is based a little bit on your PSA at the time you're diagnosed, but also your Gleason score. And the Gleason score is really what the pathologist looking under a microscope, when they look at the cells, how aggressive are these cells? A 6 is the least aggressive, a 7 is mid-range, and when you get up to 8, 9, and 10, those are the highest scores, that's what we call aggressive prostate cancer.
So we do have a question from online here. I'd like to share it. It's from a gentleman named Randy who asks, with a PSA of +5 at age 60, what is your personal recommendation? Next step with slightly enlarged prostate, normal otherwise. So when we talk about a +5, that's rather low on the
well,
scale,
I mean,
right?
what we use age-appropriate PSA values. So what that means is a 50-year-old is allowed to have or should have a lower PSA than a 75-year-old. So for someone that's 60 years of age, a PSA that would be normal would be a PSA under 3.5. And in this case, in this patient's case, or the gentleman's case that sent a message in, we're looking at a PSA that's elevated for their age. So I usually do 2 things when we see situations like this. The first thing is I usually will repeat it. We want to make sure that we don't overreact to a single value that may be high. Similar to how nobody is diagnosed with diabetes because of one sugar that's high. Nobody's diagnosed with high blood pressure because one blood pressure reading is high. Same thing with PSA. We don't want to overreact to a single value. There are also other adjunctive tests. You can look at PSA by itself, free and total fractions. So there's different ways of looking at PSA values in fractionated combinations that can really give you a clue. Does this PSA value alert us enough that we may need to go down the road of MRI and biopsy?
Good to know. You're watching Ask Us Anything About Prostate Cancer from the Milton S. Hershey Medical Center. I'm Scott Gilbert, joined by Dr. Jay Rahman, the head of our Division of Urology here at the medical center. We welcome your questions. You can add them to the comment field either now if you're watching live, or you can even add them to the video if you're watching this maybe after the fact. You're watching a playback version. We will pass those questions along to Dr. Rahman for an answer as well. One question for you about the course of treatment. It looks like Ben Stiller, he had surgery, laparoscopic prostatectomy it was called, and that was all he needed. He didn't need radiation or chemotherapy. How common is that, or is it, I guess this is another thing that's very individualized?
Yeah, so I think when you have a patient who's been diagnosed with prostate cancer, the first thing we want to know is this localized to the prostate, or is this spread elsewhere? Is it in lymph nodes? Is it in bone? Is it in liver? And I think prognosis and treatment very much depends on, is this confined to the prostate or has it gone elsewhere? Now in his case, he had a diagnosis, he had an MRI showing that it had not spread elsewhere. And so in those situations, we have several options. Surveillance, if it's a very low-grade cancer, perhaps in an older patient. Surgery, as he had, which is really perhaps the standard of care in patients who have a long life expectancy, such as he was diagnosed at age 48, life expectancy 20 or 30 years. One would argue that surgery gives the best potential long-term outcomes, as well as radiation to treat the prostate. But those are all for clinically localized disease. And if you have disease that's spread elsewhere, prognosis goes down, but also the need for systemic treatments such as hormones and chemotherapy increase.
Well, let's go back to that issue of screening, because that's really what it seems like Ben Stiller and his physician are talking about in the media today. They're saying every man over age 40 should have a discussion with their doctor. What is your guidance today, and what will it continue to be for men coming into your office, your clinic?
Sure. Well, I think for men coming into the office, I think if they're under 50 years of age, I tend to recommend not screening unless they have significant symptomatology attributable to their prostate, significant urinary tract symptoms, inability to urinate, blood in the urine, or if they have a notable family history of prostate cancer, father, brother, grandfather, multiple first-degree male relatives. Beyond that select group, I really look at men starting at age 50. I recommend that they have a discussion with either the urologist or their family doctor or their internal medicine doctor about the merits of prostate cancer screening. And that entails a little bit life expectancy, how they would deal with a diagnosis if a PSA was elevated that resulted in a biopsy, whether they would desire treatment or no treatment. And I think it's important to have these discussions up front, because there are some patients who really would not want to know and would not want to pursue treatments. And I think that's very important to have that conversation before lab tests are sent off. Beyond that, I really recommend checking PSAs with rectal examinations every 1 to 2 years for men in their 50s and 60s. And I think the importance of that is really identifying PSA trends and rectal examination trends so you can highlight and find cancers at an early stage before they are locally advanced or metastatic.
We do have another question. This is from Randy. He asked us to explain again the specific MRI used. He's asking for some details around that. Can you shed some light on that?
Yeah, so many centers use, we use, for example, here at Penn State, it's called a pelvic MRI. The pelvic MRI is with and without contrast. And what it really does is it gives us a zoomed in view of the pelvic lymph nodes, the prostate, and the surrounding structures, the rectum, the bladder, the lymph nodes, the nerves that control sexual function. And so we call it here a prostate protocol MRI, which has different sequences, T1, T2, axial, diffusion weighted, fat saturation, all of which are sort of a word salad. But ultimately what it does is it gives us multiple different pictures to get a very crisp, clear view of the prostate to determine the capsule and whether there's any penetration outside the capsule.
And again, that's a test that's done after an elevated PSA is detected. But bottom line, an elevated PSA is not necessarily a reason to panic, correct?
Correct. I mean, I think in most cases, if you look at men who have an elevated PSA, and even those that have an elevated PSA between 4 and 10, who go on to have a biopsy, only about 35% of those men at the time of biopsy will have prostate cancer. So realize that only about a third who have concerning enough features that with a biopsy have cancer, 2/3 don't. And so some of the uses of the MRI are to help refine those predictions of who may benefit most from the biopsy, perhaps to increase the diagnostic yield, meaning you'd love to have a biopsy or a procedure where more of the biopsy has a yield, thereby avoiding biopsying those who may not need it. So that's the role of the MRI.
Sure. You're watching Ask Us Anything About Prostate Cancer from the Milton S. Hershey Medical Center. I'm Scott Gilbert alongside Dr. Jay Rahman, and we thank you for the questions online. And like we said, we encourage you to continue asking those questions online. Even if you're not watching this live, you're watching a playback version, we'll make sure we get those questions to Dr. Rahman and ask him to provide a written response that we'll add to the comment field under this episode here. In closing, Dr. Rahman, any last words of advice here for people watching about prostate cancer, the real takeaway, what you want them to know?
Yeah, I mean, I think that the screening is key. And I think that knowledge about having yourself checked, having a rectal examination done, having the blood work done appropriately. I think one of the challenges is, if you look at statistics, men sort of have a macho attitude. They don't like to see doctors. They certainly don't love to have blood drawn, and most would prefer never having a rectal examination. And I think the reality is that, unfortunately, prostate cancer is not symptomatic until it has spread to distant organs, and at that point, it's not curable. So the challenge there is similar to breast self-examinations, where you can feel a lump that can help you diagnose breast cancer. The only way in some situations to know that there's a problem in the prostate before it's gone elsewhere is rectal examination and PSA. And, you know, I just finished my office hours today, and I think about several patients that I've seen who are younger guys who have PSAs in the several hundreds, who have evidence of metastatic disease. And I think to myself a little bit, these are patients who, if we had improved screening, we could perhaps identify them and capture them before we're at a phase where we cannot cure them, but we can simply treat them and try to control their disease.
And as you mentioned, there are a lot of screening methods kind of being tested, being hashed out, in addition to the PSA being...
Yeah, so, I mean, 10 years ago, we only had PSA. Now we have PSA, we have PHI, we have PCA3. We have a number of different modalities, not only at diagnosis, but if you have a biopsy and you have cancer, about perhaps predicting which ones of those cancers are going to progress. We have improved imaging, we have MRI, we have PET scans. So the technology that's available to improve our ability to diagnose, but also predict who has bad cancer or not, has dramatically improved over the past 10 years.
Dr. Jay Rahman, thank you for your time today.
I appreciate it. Thank you very much.
Dr. Rahman is Director of the Division of Urology here at the Milton S. Hershey Medical Center. He joined us today for Ask Us Anything About Prostate Cancer, and we thank you for joining us as well. We encourage you to follow the Milton S. Hershey Medical Center on Facebook so you can get a heads up about future editions of Ask Us Anything About. And as I mentioned before, if you're watching a playback of this interview, don't hesitate to add your comments, your questions here into the comment field, and we'll make sure that we get an answer for you and post that online. Thank you again for watching Ask Us Anything About Prostate Cancer today. Have a great evening.